My name's Ewan Tievendale. I'm a consultant in medicine for the elderly with an interest in movement disorders, and I have a varied job plan which involves a lot to do with the assessment, diagnosis and management of patients with Parkinson's. Often when patients present with the symptoms of Parkinson's and receive a diagnosis of Parkinson's, there is a discussion about what therapies may help them. This isn't always necessarily medication in the first instance, and often looking at the patient comprehensively using our multidisciplinary team and other allied health professionals can be extremely useful in gathering information and suggesting therapeutic options which they'll benefit from right from the outset. There may come a time within a patient's disease progression where their symptoms would potentially benefit from medication, and at that time part of my job is discussing the potential benefits, risks and side effects of those medicines in order to make sure that patients start on appropriate treatment that is likely to suit them from the outset. Patients that present to clinic, normally referred to their GP or other professionals, can present in a wide variety of ways with Parkinson's disease. There are a number of symptoms, normally around tremor, falls, posture instability, which might be the predominant one, but often a number of symptoms come to light when first assessed. My job as a consultant in assessing these patients is often to take a good story or history as to what's been going on and to examine the patient comprehensively in order to categorise those symptoms into a likely diagnosis. When patients present with symptoms, it can sometimes be quite difficult to differentiate the exact cause at that time, and there are a number of conditions that can present very similarly to Parkinson's. As a result, although Parkinson's is a clinical diagnosis, which means essentially that the diagnosis is normally given on the background of the history and the examination, sometimes tests are required, such as imaging, predominantly of people's heads, or blood tests to exclude other conditions or provide support to the diagnosis in reaching that conclusion of a diagnosis of Parkinson's. There are a number of tests we do, predominantly around a neurological examination, looking at how people walk, looking at how quickly they can do movements, examining their tremor, what makes it worse or better, and examining other aspects of their neurological system, such as power. We talk about tone or the rigidity or stiffness that they may have in their limbs. We'll often do examinations of what we call the cranial nerves, which is often looking at many of the nerves that innervate the face and are involved in things such as speech and swallow. And this builds a comprehensive examination picture which then provides either support towards a diagnosis of Parkinson's or alternatively may indicate other conditions. When patients are likely to have a diagnosis of Parkinson's disease, it can often be a daunting prospect in giving them that information. There's a number of challenges which you face both as a clinician in order to deliver that information in a way that the patient can understand in a sensitive manner, and also establish at that time what the patient wants to know. Therefore, often in delivering that information, it's important to get an understanding of what the patient understands is already going on. Some patients, when receiving the diagnosis, may already have a strong suspicion that this is what's going on and may have already prepared for it. Other patients, this will come as a very significant shock, and therefore the delivery of that diagnosis needs to be in a sensitive manner, understanding what the patient wants to know, already understands, and often that can mean giving some information initially around the diagnosis and then promptly following them up either through seeing them again or through the Parkinson's disease nurses to allow them time to digest that information around the diagnosis and time to think of questions that they would want to ask about it. I think one of the things that I often discuss with patients when they receive a diagnosis of Parkinson's disease in my clinic is we have to discuss the unenviable prospect that unfortunately it's a progressive neurodegenerative disorder, meaning that over time things will potentially deteriorate. I think, however, it's important at the outset to say to patients that there are lots and lots of potential interventions both through seeing various therapists and as part of the multidisciplinary team, or through medication, which can maintain a very good quality of life for potentially a good length of time. There is a lot of variability in how patients may deteriorate, but there are patients that I have under my care that have had Parkinson's disease for many decades with a good quality of life because they are on the right treatment for them, seeing the right therapists and supported by the right team. With respect to following patients up with Parkinson's disease, the frequency of which a consultant may see a patient will depend very much on the patient's symptoms. Patients with more complex disease that are on more complicated regimes may require more input than a patient who is very stable with their disease. Having said that, because Parkinson's disease is a progressive condition, patients' symptoms often change over time, and then that's why the follow-up is so important in maintaining an overview of those symptoms. If patients need to get in touch in between time, we have a system through our Parkinson's disease nurses that they can ring up any time and leave a message or speak to one of the nurses to explain the problems and symptoms they have at that time. If that then requires further, more comprehensive review from a consultant, then the Parkinson's disease nurses will flag that, and that will then prompt a sooner review in clinic, or alternatively in certain circumstances may even lead to a review in the community. As part of patients' follow-up with Parkinson's, I often have discussions about medication, which can be very useful in treating many of the symptoms of Parkinson's disease. It's also important, however, that we realise that it's not just medication that can have a dramatic impact on patients' symptoms and quality of life. Often through using our multidisciplinary team and seeing other allied health professionals, we allow patients to benefit from not only the pharmacological management, the tablets and other medical interventions that patients often find themselves on with Parkinson's, but also benefit from the skill and expertise of other allied healthcare professionals such as physio, occupational therapy, speech and language therapy, dietitians, to name but few, as these professionals could also have a very significant role in improving patients' symptoms. And in fact, it's a combination of all of these things, the multidisciplinary team management with the medications, that empowers the patient to have their symptoms as well controlled as possible. There may come a time within a patient's disease progression where their symptoms would potentially benefit from medication, and at that time part of my job is discussing the potential benefits, risks and side effects of those medicines in order to make sure that patients start on appropriate treatment that is likely to suit them from the outset. It's important to realise that even from the very presentation of Parkinson's disease, that it's not just about the mobility symptoms that it often presents with. Often patients have a wide range of other symptoms, what we traditionally call the non-motor symptoms, which may relate to things like mental health problems such as depression, anxiety. They may have cognitive difficulties. There may be problems with things like the bladder or bowels. There is a whole range of non-motor symptoms which can cause equally challenging symptoms for patients, and it's important to address these just as importantly as it is to address the rigidity, the stiffness and tremor. Some of my role is not necessarily about just seeing patients in clinic. It's about having an overview of the service. It's about looking at areas within the service that we could try and improve for the benefit of our patients. So it's about engaging in audit, quality improvement, in order to make sure that our patients, one, are seen in a service that is keeping up to date, two, is embracing new treatments if they come along, three, is creating streamlined pathways so that patients can gain access to treatments, particularly around things like complex therapies, and also making sure that if patients do have complications such as admission to hospital, that there is protocols and processes in place within the hospitals, such as mill-by-mouth protocols, and such as lots of the education that the Parkinson's disease nurses do with ward staff in order to ensure that patients are as well looked after as possible if they should inadvertently need an elective procedure or have an acute deterioration for something related to their Parkinson's or not.